Good afternoon, everyone. Good afternoon, our Dokutal family. Welcome to another session of this presentation. I'll be taking today's presentation. The topic is triage of surgical abdominal conditions or triage of surgical emergencies. This a general surgery topic to be specific. Yeah, so we'll make the presentation under the following outline. We'll look at the introduction. Uh, we'll talk about how COVID-19 have affected surgical management of patients especially in this part of the country. Then we'll talk of Nigeria and then worldwide. Then we'll talk of the source of infection that's taking into account a surgical or health workers specifically. Then we talk of changes in delivery of surgical care during this pandemic. We'll now talk of the triad of these patients in elective cases, then in emergency cases, then we'll conclude finally. COVID-19 have hit the world as a pandemic generally. In recent months, almost everyone has been devastated by this condition, which is a severe acute respiratory syndrome, coronavirus 2, SARS-CoV-2 to be specific. It has impacted almost everything worldwide, the economy, health sector, then the personal life of everyone, health workers, especially because we are at the front line. So we are the ones coming in contact with these patients. It's a silent enemy because not everyone actually exhibits symptoms. So many a times you come, meet a patient. Surgical patients generally we can classify them into three. Okay, let's say there is one of the group that will come with a surgical condition, and then he also has COVID-19. He may exhibit the symptoms. So from onset, one may be suspicious of that patient, and then you take necessary precautions. Then there are patients that come with surgical conditions, but they don't have that COVID-19. Then while on admission, we may serve as the source of infecting that patient, either through an infected person, or maybe we as health workers may be infected, and then we now end up infecting our own patient. So it has brought the entire health sector into a crisis mode. This guideline that we're going to look at is to provide advice for surgeons and to serve the best interest of the patient based on estimate of risk average of the patient. For most patients who are known to be COVID-19 positive or at high clinical suspicion for COVID-19, non-operative management is prepared if feasible and safe for the patient. Now, if operation is required in this patient, then appropriate personal protective devices should be utilized and precautions should be taken to protect the healthcare team. Remember that you are still in contact with the society and then the family. So one needs to take care of himself. So the transmission, when it comes to surgical patients, is through, generally is through particles, either through aerosol, fomites, or through direct contact. That's why we advise patients where ourselves not to be touching our eyes, nose, and mouth, because it's both through aerosols and then through contact. Now, any hospital need to strike a balance, okay, between the surgical service that you need to render in that center and then protecting the personnel themselves, okay, then continuing care of acute surgical conditions and managing these urgent or elective or emergency cases. So generally in this part of the country, one thing that we did in the outpatient departments, what we did is we limit the number of patients that we see in the clinics. Patients that are coming as elective cases that can wait. I'm talking about patients with, let's say, benign breast diseases, with lipomas, or patients with thyroid diseases, for example, benign thyroid diseases. These patients, we normally give them long bookings. Okay, patient will come, we'll see him, then we'll advise him to come back maybe in 3, 4, or even 5 month time. So each hospital should come up, I know, came up with their own plan of their own system. generally, the elective patients that we allow to be coming are malignancies, patients with breast cancers, colorectal cancer. Those patients cannot wait. So they are now considered other emergency elective cases. So these patients, they will keep on coming, we'll see them, and then we'll subsequently plan them for surgery. But any other person, we give them a long booking to come back after 2 or 3 months. So next slide, reducing the elective activity, as I mentioned, including day case surgeries. So it had its own benefits. First of all, it releases general ward and ICU beds, therefore increasing capacity of patients infected with COVID-19. So we have ample beds for admissions and other things. Second, it releases surgeons and the theater team to perform drills and then support wider emergency care. If there is need, maybe the surgeons can be invited in the management of COVID-19 patients if they are short of staffs. Then third, it reduces the risk of cross-infection of elective patients and then hospital visitors with COVID-19 by infected patients and staff. So it prevents subsequent spread of the disease. All in all, when do one operate an elective case? The American College of Surgeons came up with a scoring system. There are actually 2 types. There is elective surgery acuity scale, and then the medical necessary time sensitive scoring prioritization. These ones, I'm just going to talk briefly about them, but to simplify everything, what they did was, okay, let's go to the next slide, was to come up with a scoring system. And in that scoring system, if one fall within if the score is high, then they now say it's okay to proceed with the surgical intervention of that patient. If the score is very low, then operation is not justified for that patient. Then those ones that are in between, you give them maybe 2, 3, 4 weeks. You keep them up down observation, and if subsequently they fall, you score them further after some weeks, they fall lower on the scoring system, then you don't need to operate on them. If the score became higher after a few weeks, then you can proceed to operate. So when do one actually operate emergency patients? Because even now, the word emergency, we have actually found another way of managing this patient. Back then, when patients present with acute appendicitis, it's operation for everyone because it's an emergency. Now, different school of thought are now trying to say, okay, maybe we should operate on this and not on this group of patients. So the word emergency, COVID-19 have actually made us to redefine it in a way. So non-operative management should be considered carefully in patients. This should be considered if resources are limited, and then, all right, let's just go to the next slide. This one, they are just talking about how to organize the surgical emergency in all. That adequate theater should be provided, and with a cross ventilation and all that. Is for this one was actually a suggestion by American College of Surgeons. So I think in this center, well, in this our own environment, it's not feasible because you can't actually construct a new theater because of this. So the risk of surgical team members cross-infecting patients and other staff is high. So they advise that we optimize the team by doubling or cross-covering rotas, okay, in anticipation of a high level of staff absence. Because some of the staff will be infected, so you should expect that there will be specific time where you have shortness of staff. Then you reduce doctor to patient ratio in some part of the hospitals, and then you augment the surgical team, calling back retired surgeons, and then maybe clinical academics that are not actually into operating patients and stuff like that, just to make up for the lost number of the patient of surgical staffs. Okay, so throughout the management of the patient, we should also remember to maintain social distancing. Face-to-face meetings should be avoided as much as possible. What we did here in Kano, for example, was to cancel all face-to-face meetings. Presentations were doing via Zoom, and teleconferencing was also introduced. For some patients that were operated, instead of us to ask them to be coming back, we gave them phone numbers, so we were following up via phone calls. If there is need or there is suspicion that there is any complication, that's when we call back our patients to come into triaging of these surgical patients. We took into account many other things. First of all, the condition that the patient is presenting with. Is he coming with any complication? Is he going to benefit from medical treatment, or has he been on medical treatment before? And if he has been on medical treatment, how has he been faring with the medical treatment? Is he improving or not? So those are things that we normally consider before deciding whether to operate or not. So the goal of it is to provide timely surgical care to patients presenting with urgent and emergent surgical conditions while optimizing patient care resources and preserving the health care givers, obviously. So while all that is being, we should also remember there is no substitute for. So I've already mentioned this one, that who are those patients that are going to benefit from surgical or non-surgical treatment. So patients who have failed attempt at medical management of a surgical condition should be considered for surgery. I mentioned that one. Then the decision should be multidisciplinary. The patient should be brought into the discussion so that he will have an idea what he has, and the decision should be taken at different levels. So let's go to specific conditions now, so that we'll discuss what have changed in surgical management of some of these treatment, some of these surgical emergencies. Now, acute hemorrhageal thrombosis or necrosis usually it's non-operating management. What we normally do for them is we give them painkillers, we ask them to do seat bath, we give them drugs like Daflon. Okay, this actually tend to reduce the venous congestion of the hemorrhageal vessels. So this one, we still maintain it. Now, emergency surgical procedure should be considered only for those that have failure of this treatment, and but otherwise, up till now, we maintain non-operating management for acute hemorrhageal thrombosis and necrosis. Perianal and perirectal abscess. Okay, this one, because of the area that is involved, is perineum, is very painful, the area. So what we normally do is to do examination under anesthesia, either spinal anesthesia or general anesthesia. The patient is examined generally, and then this abscess is drained under anesthesia. Now, because of this COVID-19, it's now agreed that perianal abscesses that are superficial should be managed in incision and drainage, but under local anesthesia. But that one is also the surgeon's preference. But deeper abscesses, like this picture is showing, if there is supra-elevator abscess or intersphincteric or ischiorectal abscess, these ones are normally deep and large. So there is no substitute for surgery in this kind of patient. So patients should be admitted, and then surgical treatment should be offered for them. Next slide, so that we see the surgical. So this the surgical management treatment that we normally offer. We make a cruciate incision over the swelling, okay, where the abscess is. So one will be left with a flap of skin after making that cruciate incision. So this flap of skin should be excised. So at the end of the day, you are having a diamond-shaped wound, okay, as we can see up there. So this diamond shape, we should be irrigated with saline, and then patient should be treated with antibiotic and sick bath. So the whole area will now granulate from inside out. So this one is for deeper abscesses, okay? All right, so let's go to the next slide. So soft tissue infections like cellulitis, the management has not changed. Is antibiotics, pain management. We ask them to elevate the limb so that the swelling will reduce. However, if there is large abscesses or necrosis, then that patient have clear indication for surgical intervention. That is debridement. For patients that are coming with bowel perforation, intestinal ischemia, or closed loop obstruction, this one there is no other way for it. There is that the patient need surgical intervention. However, for small bowel obstruction due to adhesions, that one, the usual treatment is non-operative adhesions. We pass NG2 for the patient. We give fluid management, and then we observe him for around 48 to 72 hours. It normally resolves after some time. So it's non-operative management for adhesions, while the other ones that I mentioned is clear-cut surgical emergencies through exploratory laparotomy should be done for them. For appendicitis, this is another pathology that COVID-19 have made us to actually change the management. For appendicitis, there is pathological classification of it. It can be obstructive and non-obstructive type. The obstructive type is there is actually obstruction within the lumen of the appendix, either mainly through fecolite. That's what obstructs the appendix. Then there is the non-obstructive type, normally seen in winter period when patients have upper respiratory tract infection. There is hyperplasia of lymphoid tissue around the small bowel, including the appendix itself. So for the obstructive type, they have the non-obstructive type, sorry, they have uncomplicated type of appendix. There's a study that was done, mentioned down there on the slide, CODA collaborative study. This one, they found out that antibiotics for patients that clearly don't have obstructive type of acute appendicitis actually suffice. Okay, it has similar outcome as operative management. So they are advising us to be giving patients antibiotic as long as you can rule out that the patient doesn't have obstructive type of appendicitis. So for the obstructive type, obviously, if you don't operate, they tend to come with complications. So these complications include perforation, appendix mass. They may have peritonitis. That is either pelvic peritonitis, right iliac fossa peritonitis, or generalized peritonitis. So those ones are the ones that have complicated appendicitis. So for these ones, for patients that have appendix mass, through there is Oshinasheri regimen that we normally do for them. We give them antibiotics. It tends to resolve after some time. Then after 6 weeks, they come back for interval appendectomy. For patients that have mild or small abscess formation, that one you can actually aspirate using ultrasound guidance. So the patient may obviously have the appendectomy done at a later date of time. But if there is purulent accumulation, either pelvic abscess or generalized peritonitis, those are the patients that we now advise to go for open appendectomy, either open or laparoscopic appendectomy. Okay, so for hepatobiliary conditions, the changes are also similar to that one of acute appendicitis. We have ascending cholangitis, we have calculous cholecystitis. Okay, next slide. All these conditions have the usual way of managing them is either through antibiotics, and then you wait after 6 weeks when the inflammation has subsided, and then one may intervene. They have interval cholecystectomy for most of them. So for cholelithiasis, the patient is symptomatic. The management is, as I said earlier, is through antibiotics. Okay, we delay the surgery until after like 6 weeks. That's when the inflammation in that area have actually subsided, and then in intervention, once one want to intervene, the area will be clear for one to actually operate, and bleeding is less. And other factor that one need to consider is if there is actually failure of this emergency of antibiotics treatment, then one may need to go and intervene early. So choledocholithiasis, the treatment is similar to that one, but with the only addition of endoscopic retrograde cholangiopancreatography that can be done to drain this obstruction. Okay, so normally if there is a stone impacted stone within the lower part of the common bile duct, one may do ERCP through the sphincter of OD. One may dilate it or do a sphincterotomy, see the stone, and then evacuate it. Otherwise, the management is similar as that of cholelithiasis that I mentioned. For acute cholecystitis, the patient may obviously go laparoscopic cholecystectomy. This will minimize hospital stay. Patient will be operated today. After a day or two, they may be discharged. If this kind of facilities are not available, then one may consider IV antibiotics for these patients until the acute stage have resolved, and then patient may come back later on, maybe after 6 weeks, to have interval cholecystectomy to be done for them. Cholangitis is normally a complication of cholelithiasis that I mentioned earlier. The usual management for it is to give antibiotic and then drain this biliary tree. Okay. The usual way of draining it actually either laparoscopically or open, but then there is a ultrasound guided drainage that can also be done. The gallbladder can be identified. It can be cannulated with a pigtail catheter, and then the whole biliary tree can be drained. Then once infection has subsided and inflammation has subsided, then cholecystectomy can be done at a later date for this patient. Then for diverticulosis, which is presence of multiple diverticulum, the presentation differs for most patients. Okay, most patients, almost 70% are asymptomatic. So if a patient is coming to you and then it's an incidental finding of diverticulosis, then one may just observe this patient until when he develops symptoms for one to intervene. However, if there is inflammation, that is diverticulitis, then the treatment has not changed. It's antibiotics. Okay. Usually we start by IV antibiotics. After 2 or 3 days, we convert them to oral. However, this diverticulitis can become complicated. There is what we call Hinche classification of diverticulitis. Class 1 and 2, they have like localized abscess around the colon. So this one, you can have percutaneous drainage of that abscess, and then you follow up with antibiotics. Patient will do okay with it. However, Hinche class 3 and 4, this one have widespread peritonitis. Then the treatment is obviously you have to intervene through open management. That's laparotomy. You open, you intervene, and that's it. Another complication of diverticulosis is obviously bleeding. So most patients present with mild bleeding. So these ones you manage non-operatively, unless it's a massive bleeding, or you probably have admitted the patient, and then while on admission, he now developed further bleeding, which is life-threatening. Then one may have to intervene in that in this case. All right, so these are the few surgical conditions that generally have had a little change due to this pandemic. So in conclusion, COVID-19 is mainly transmitted via droplets and contact. Health workers are not immune to this infection, so we should all be vigilant of it. and take care of ourselves. So regional anesthesia should be considered where feasible, obviously, because general anesthesia, you have to intubate, you'll be looking at the throat of the patient, so coming in contact with aerosols is higher. Disease transmission can be minimized when preoperative care is thoroughly planned. Admission or surgery should be offered only to those patients with clear benefits. Okay. Thank you very much for listening.